Hey everybody, thanks for joining us for another TOTEM talk. Tonight we've got two speakers, which is awesome. It's a another FUSIC HD case review with Hannah, and joining her tonight will be Piet. So Hannah, you all know, doesn't need an introduction to TOTEM, but for those who are coming to us for the first time, Hannah's a cardiac ACCP and a professor in advanced clinical practice. She's got a lot of experience doing and teaching echo. She's got level 2 accreditation in TTE and TOE, and is the national lead for FUSIC Heart. So a really fantastic person to have presenting FUSIC HD case reviews. And for the first time tonight, we've got Piet-Theron Jansen. Piet, I have met through my time in South Africa. He is someone who's very passionate about critical care echo and has started a I guess, national WhatsApp group called Echo Snippets, where there's loads of echo sharing and teaching, sort of daily snippets and weekly live case reviews. So he's doing a great job there, and thought it'd be nice to include him in TOTEM, bringing in some of the South African cases that he comes across. So thank you both for joining us tonight, and I'm going to let you guys take over and mute myself. Please, everybody, keep yourself muted unless you have a question, and I will share the feedback form on the conversation now so that people can fill it out before they leave, if they leave early.
Thanks, Samson. Very kind of you. Nice introduction once again. Piet, just in case nobody can see your lovely face, here it is again. He gave me his permission to do this, by the way, guys. I didn't just go and stalk him on Twitter. Pete, do you want to just introduce yourself?
Yes, I'm a senior registrar in Anaesthesia. I live in Bloemfontein, South Africa. Preparing for my final exams will be in January of 2026. Eventually, I see myself going into critical care, probably full-time. I dream of doing either the BSc or the accreditation after my final someday. Just to give you a bit of a background of South Africa and the echo landscape, we don't have any formal accreditation like you guys do with the BSc and the FUSIC. So a lot of the people eventually end up doing either the European route or the UK route. There are some people that go through the American route as well. So here we have what we call FATE courses. It's really just a point of care type of cardiac things, and that we use in anesthesia specifically. And it's so this FUSIC thing is a new thing for me, in the sense of I'm not used to writing formal reports, if I can state it like that. So in FATE, it's really a lot of binary questions, yes or no, perioperative scanning, etc., etc. So this is a really nice opportunity for me to get to see what the rest of the world is doing. So thank you for the opportunity. I really appreciate it, and I hope everyone learned something tonight.
I'm sure they will. Thank you very much. And if anyone wants to tap up Pete afterwards, there's his Twitter tag. Okay, same as we did before, guys. If if you want to get involved at home, please do. These are the beauty of these sessions. So I have, as I always do, put together a quick case review form. Don't worry if you don't want to, because you can just sort of interject at any point and give some sort of ask some questions. But sometimes people like to actually report as they go along. So if you want to do that, then you just use this QR code here. Just a quick reminder of what we did last time. So what I don't want to do is obviously confuse the issue when it comes to people that are on the FUSIC HD pathway. As is always the case, when you're looking at sort of general cases, you do sometimes have things that fall outside of the scope of HD, and I have identified them within the scan. So for those who are doing the accreditation, you know what not to do. A couple of learning points which I'll talk about in the second half of the session after Pete's given his case presentation, and any important pathology will be flagged up as we go through. So I'm going to hand you over to Pete now. I'm going to mute myself, and then I'll pick back up again when you're finished.
So the case tonight is about a 24-year-old female. She presented to the cardiology clinic with the history of having a recent CVA and also a new diastolic heart murmur. So I got involved when we had to see the patient for pre-anesthetic assessment. She was booked for cardiac catheterization and for TOE. Vitals were okay, BP 102 over 58, pulse of 90, and she had a right hemiplegia, so she was unable to walk to get her weight and her height. So the indication for the TTE was a heart murmur and a CVA in the young person. Next slide. So this is the first view. So it's a parasternal long axis view. So when I look at this, I start literally from the top to the bottom. You start with your right ventricle, more your proximal RVIT in view. And then the next wall is your interventricular septum. If you want to be a bit more fancy, you can call it the anteroseptal wall. And then you see the right coronary cusp from the aortic valve. And I always try to remember the right cusp belongs to the right ventricle. And then the bottom cusp is a bit of a catch out that can be either the left or the non-coronary, depends on, I guess, the angle where you're cutting it. And then the LVRT and the outflow, and then what follows is the mitral valves. The first one you see is the anterior mitral valve leaflet, and you remember that your anterior mitral valve leaflet always belongs to the aorta. So the valve leaflet closest to the aorta is always going to be your anterior mitral valve leaflet. The bottom one is the posterior leaflet, and then right at the bottom you've got your infralateral wall, and some people would say call that posterior as well. And then bottom right is your left atrium, and then you also see a small portion of your left ventricular cavity in this view as well. Next slide. So I asked Hannah to include this slide because I made a very obvious mistake. So this is a M mode put through the parasternal long axis, and then you cut through the interventricular septum or the anteroseptal wall and then the inferior wall. And then you want to see the thickening and the relaxation of the muscle. And this is where you perform your Tychol's measurement to get your stroke volume and your fractional shortening. So what happened is the first measurement is supposed to be the diastolic measurement, but I put it up as the systolic measurement for the machine. And then the second measurement is supposed to be the diastolic measurement, but I put it as the systolic measurement for the machine. So at that time of the day when I was doing the scan, I couldn't understand what's going on. And eventually after reviewing it for this talk, I saw the stupid mistake that I made. But irrespective, I mean, you can still take the measurements and calculate your fractional shortening. So just a reminder, fractional shortening, your end diastolic volume minus your end systolic volume or diameter, and divided by your end diastolic diameter. Okay, next slide. This is, I guess, a zoomed view of the mitral valve and a bit of the submitral apparatus. And what I want you to see, it was present in the previous view as well, is that anterior mitral valve leaflet looks like it's bowing, you know, it's not opening properly like it should. And it looks like the tip of that leaflet is bending. Some of you might have read about the hockey stick sign, or, you know, the hockey sticking. So that's the first issue that you see here. And another issue is that if you look at the submitral apparatus with the papillary muscles, it looks a bit thickened as well. So that's already two features of that's a papillary muscle. That's already very indicative of significant for rheumatic mitral valve disease. So that hockey stick sign and the submitral apparatus that's involved. Next slide. So that is color over the aortic valve. And what you can see, there's flow going forward through the valve. and then a whiff of regurgitation, going backward. And so that's just indicative of mild, very, very mild aortic regurg. And I think a tip that I always try to remember of what we see commonly is, sorry, I just need to stand up quickly. So what you see commonly with mitral valve involvement is that the aortic valve is involved as well. And so yeah, you can just see some regurgitation, but the mitral valve the aortic valve leaflets didn't look that thickened or initially. So just a very mild visually aortic incompetence. Next slide. This is a still image in systole of the LVOT, and what I tried to measure was the LVOT diameter. So just to remember is that you measure it in close to end systole where the valves are open, just about 0.5 to a centimeter away from that attachment, and any value above 2 centimeters probably considered as normal. Next slide. Please just excuse me for 2 seconds. I want to sort out my daughter quickly. Sorry for this.
Hannah, I think you're on mute. We can't hear you. I can't hear you anyway.
Aha, thank you very much, Chris. You know, after all these years of being on online meetings, you never quite get the knack. Oh, you're back in time, Pete. Hopefully everything's okay. You're on mute now, actually, Pete.
Sorry, I'm back. Sorry for that. I'm a dad and I'm home alone with the kids as well.
Yeah, that's fine. Carry on.
The next one is supposed to be a zoom view of the ascending aorta, and what I tried to measure here was the aortic sinus and then the sinotubular junction and a bit of the ascending aorta as well. The ascending aorta is probably not the best measurement that I could do, but I think the idea is here you measure it in diastole, and as I have it, you measure it from with leading edge to leading edge. So nothing really that stood out to me that's obviously massively dilated or abnormal, yeah, in this view. Next view. This is again a still image of your parasternal long axis. Really a lot of stuff you can get from here, and I try to measure the ascending aorta and the left atrium, and I try to remember it like that it should be close to a ratio of 1:1, meaning the sizes should be approximately the same. And here you can see the left atrium is about twice the size, close to twice the size of the ascending aorta. Next measurement. So this is a right ventricular inflow view. So you get this going from your parasternal long axis view, and then you aim your beam of the ultrasound towards the right hip, the patient's right hip, and then you can put some color on, and then you're literally looking into the right atrium. You see the tricuspid valve, and if I have it correctly, it's the anterior and the inferior leaflet, and then a portion of the right ventricle. And with the color here, you can see there's some tricuspid regurgitation. This is a nice view. I like to teach this to people because you can sometimes get a very nice Doppler angle for your CW to measure your tricuspid velocity from here. Next slide. So this one is from a right ventricular outflow view. So this is then the other side. From the inflow view, you just scan upwards up to the left shoulder, and then that's a pulsed wave Doppler put just there in front of the pulmonary valve. there where the pointer is. And you can see it's pulsed wave because you can see the outline of the triangle nicely. It's not colored in or filled in, as you would say. Probably not the best trace. You can see there next to the triangle on the right-hand side, there's what looks like the closing click of the pulmonary valve. So you'd want to see that a bit better, I guess. And you can do two things here. Your right ventricular outflow tract VTI, which is 12.13 centimeters. It just says with every heartbeat, that red blood cell travels about 12.13 centimeters per cycle. Normal, I guess you would try to compare it with your LVOT VTI, and it should be approximately the same. Normal, I would say close to 16, 17 centimeters. So some mild reduction in right ventricular function here. And next slide.
What's your other sticker?
He's my listening. So sorry, this is Isabel. She's going to sit with me. So this is again the same view that you got the RVT VTI on. You can do your pulmonary valve pulmonary acceleration time, and it's that 0.120 seconds or 120 milliseconds. And it's just an indication of the acceleration or speed that it takes, or the time it takes for the blood to flow into the smaller pulmonary arteries, and also just an indication of pulmonary hypertension, probably the pulmonary vascular resistance, but a lot of caveats to it, and it should be interpreted within context as well. But anything above 100 milliseconds, I would see as normal. Next slide. This was the slide or the segment where you get that RVT from. So again, you get this by going from your parasternal long axis view and then looking up a bit towards the patient's left shoulder. So you can see in the middle of the picture, it looks like the left ventricle is there, and then on top it's your pulmonary valve and your main pulmonary artery with the RVT, the distal RVT, and the top or the near portion of the beam. And what you can see with the color, there's also a very, very small width of pulmonary valve regurgitation. Now we're getting to the good stuff. So this is a parasternal short axis view. So from your parasternal long axis view, you take your probe, rotate it 90 degrees with the probe marker pointing to the patient's right shoulder. And then you can basically scan from the aortic valve down to the mitral valve to the papillary muscles. So this is at the papillary muscle level. You can see the left ventricle in the middle of the screen, the donut, and then the right ventricle sits on the top left. And then what Hannah did there, here you can look at a couple of things. You can look at, you can get an idea of the volume status. You can look at the contractility and the different segments for regional wall motion abnormalities. And if you go through it, from the top is your anterior segment, and then directly opposite to that is going to be your inferior segment. And then you can divide it into septal and the lateral segments. And then the septal and the lateral segments can be divided in two again. You get anteroseptal and infraseptal, anterolateral and infralateral. And this lady did not have any regional wall motion abnormalities. Next slide. So here's where it becomes a bit interesting. So this is still parasternal short axis, but it's now at the level of the mitral valve. Sorry. So a couple of important things you can see here. The first valve that you see on the anterior aspect is your anterior mitral valve, and then the bottom one is the posterior mitral valve leaflet. And then you can also look at your commissures, the posterolateral commissure and the anteromedial commissure. And then you can see here immediately that your commissures look really thickened or calcified rather. And then your anterior mitral valve leaflet seems to be moving normally for me. And your posterior mitral valve leaflet definitely looks like it's not doing as much as the anterior mitral valve leaflet. And it also looks like there's an issue with the coaptation. It's not complete in some parts of the loop. So I would expect there might be some mitral incompetence with the stenotic valve. So this is typical of what you'd see with the rheumatic valve. The posterior mitral valve leaflet is involved with the commissures as well. Next one. This is now a color picture, and this says exactly what we saw on the 2D picture. So if you slow it down a bit, you can kind of work out what's happening with the color that you're seeing. You'll see if you're in diastole, so that at that stage where Ina is at now, it's at systole. So it looks like a blue jet, and blue means it flows away from the probe. And I remember it like you're sitting in the left ventricle and looking up. So if flow flows away, the color is also always going to be blue. And then at some stage during diastole, if you look at the ECG, you see some that aliasing with really a lot of turbulent flow there. So that's typical of incompetent a stenotic valve lesion. So mixed mitral valve disease with this lady. That's what I would call it. Next one. This is a parasternal short axis, a bit higher up, closer to the aortic valve in the middle. And you can see a portion of the right atrium and the right ventricle there. You look for tricuspid incompetence here. The other thing that's quite apparent there is if you look at the interatrial septum there at the bottom, it kind of bulges into the right atrium. That would signify increased left atrial pressure for this patient. Here is the same view, just shifted a bit to the RVRT or the distal RVRT in the pulmonary valve. Very similar to what we saw in the earlier view, just a very small whiff of pulmonary valve regurgitation. You can't see everything really like you want to. Here is a better view of the aortic valve with the right coronary cusp at the top. Remember I said right always belongs to the right ventricle, and then the non-coronary cusp borders on in the interatrial septum, and the one that's left is the left coronary cusp. This is a zoomed view of that aortic valve in here. You can check for the morphology of the valve. Looks like 3 valve leaflets. And if you look at the color, you can see that really minimal aortic regurgitation present in this view. Nothing really else that's very much strange about the cusps or the movement. Yeah, this is lower down. Again, the left ventricle and the parasternal short axis view. This is more to the apex, and I guess I just did that to be complete. You're supposed to look at the left ventricle from the apex through the midsection to the apex. And here you can divide it again into 4 segments. The next view is apical 4-chamber view. From the top is going to be the left ventricle on your right side of your screen and the right ventricle on the left side of the screen. And then you can see the mitral valve obviously looks abnormal visually. And then the really big left atrium that's apparent on visual inspection, and the right atrium as well. And you can also get the idea of that interatrial septum that pushes into the right atrium, just signifying the left atrial pressure should be increased. Again, if you look at the mitral valve's movement, remember it's very close to an apical 5-chamber view, so the aorta will open up there in the middle at the septum. So the valve leaflet closest to that is going to be your anterior mitral valve leaflet. And if you look at the valve itself with the tip of the leaflet tips, it it really looks thickened with impaired mobility. And if you look at that short segment of the posterior mitral valve that you can see, there's also some definitely impaired mobility visible there with it bowing or the hockey sticking again that you can see in this view. Visually, I would say the left ventricle looks a bit dilated for me, especially the midsection and probably the apex as well. Function, I wouldn't say normal. I said mildly decreased on the day with this view especially. But if you look visually at the base of the heart and with the color, looks like the MAPSI should be close to normal with the TAPSI as well. Sorry, you can continue, Anna. This is a color view over that mitral valve. And again, here you can see that weird looking jet that's directed upward into the left ventricle, strange with the aliasing and that nice piezo type of radius that you see there. Again, indicative of mitral stenosis. This is a continuous wave Doppler with the marker through that weird jet that we saw in the previous picture. And you get an idea of the inflow through the mitral valve. And you can then do a couple of measurements. This is the pressure half time. And you can approximate or calculate the area of the mitral valve from the pressure half time. And I did it as 1.02 centimeters squared, which would fit in with the moderate, close to severe mitral stenosis. And I guess I'm still trying to figure out how to explain it so that it makes sense. Has to do with the speed or how long it takes for the equalization between the two chambers. Then on this slide, you can see on the left there, I traced the VTI of the mitral valve, and this is just to get an idea what the peak and the mean gradient over the valve is. And you can also use this to kind of classify or categorize the severity of the mitral stenosis. So with a mean gradient of above 5, that would also be seen as moderate, if I understand it correctly. We can continue. The next slide is supposed to be an approximation of a MAPSI or mitral annular plane systolic excursion. So it's an M-mode cursor put through the lateral annulus of the mitral valve, and then you measure from the top of the peak to the trough, and anything above 11 or 1.1 centimeters is supposed to be normal. Below 1.1 is seen as abnormal or abnormal systolic function. So just an estimate of the systolic function. So this is I try to show a RV focused view. So visually the RV doesn't appear to be dilated. There's some color over it. You can see really minimal tricuspid regurgitation at that side. RV function overall, the free will moves, the base of the RV also moves normal for me. Then you put a continuous wave Doppler through it, and you can get a pressure estimate between the two chambers, 23. That's also 2.4 meters per second. Anything below 2.8 that's supposed to be normal. And this is again an M mode put through the lateral annulus of the tricuspid valve. And then again, you get an idea of what the TAPSI is, or the tricuspid annular plane systolic excursion. And anything above 17 or 18 millimeters or 1.7 or 1.8 centimeters should be normal. And then I always try to do a S prime measurement. So you do tissue Doppler, and then you put your pulse Doppler gate there at the lateral annulus, and then activate your tissue Doppler, and then the wave above the baseline is always going to be your S wave or S prime. always also just an indication of systolic function, and anything above 10.5 is supposed to be normal. This is a view I struggled with. It's supposed to show the apical two-chamber or classical long axis with the left ventricle at top and the left atrium at the bottom. I guess with the left atrium that's a bit enlarged, it gets a bit more difficult to do it. But the idea was just to show another view of the mitral valve again. And obviously you can see, I don't see the classic parachute thing with that two-chamber, but you can again see that anterior mitral valve leaflet with the bowing, and it looks thickened, especially at the tips. That becomes visually apparent, and with the Doppler signal, you can also see the stenotic lesion that you appreciate there. So this one is a bit easier. So from your long axis, you can turn your probe again to about 110, 120 degrees. And then you can see from top to bottom the right ventricle, and then the left ventricle and your left ventricular outflow tract, and with the aortic valve. And at the bottom, you can see your mitral valves again, with the anterior mitral valve leaflet close to the aortic valve. And again, the thickened leaflet with the bowing or the hockey sticking becomes really apparent there as well. And the enlarged left atrium again to compare it with the aortic valve. So in summary, the left heart findings, I said systolic function mildly reduced, visual estimate of the EF between 40 and 50%, the fractional shortening measured then was 22%, the wall motion, no features of regional wall motion abnormalities, the pericardium was also visualized and normal with no effusions. The obvious apparent pathology here was the mitral valve. There was doming of the anterior mitral valve leaflet, or the hockey stick appearance. There was tethering and thickening of the leaflet tips. The subvalvular apparatus was involved. With the color flow, you saw a lot of turbulence, centrally directed, and it was mostly a diastolic jet with aliasing. On the continuous wave Doppler, I got a gradient of 11 over close to 7. Mean of 6.91 with the pressure half time corresponding to a mitral valve area of 1.15. And then the left atrium also appears enlarged, and I only performed a visual assessment there. The aortic valve was normal, 3 cusps, normal movement with minimal central aortic regurg observed as well. The LVOT and the aortic assessment, no really obviously abnormal measurements. LVOT 2 centimeters, valve annulus 1.7, sinus 2.5, FTJ 2.1, and the ascending aorta 2.4. For the right heart, it looked visually normal with normal function as proven by the TAPSI and the S prime measurement. I thought the RVOT VTI had a mild reduction and a normal PV acceleration time. We didn't show images of the IVC, but visually it appeared normal. The expiratory diameter was 1.8 centimeters with more than 50% inspiratory collapse. Focused valve assessment on the right side, really minimal TR visualized with a TRV max of below 2.8. Also minimal PR visualized with the MPA that was measured at 2.1, and that was normal. Lung ultrasound for this patient was normal sliding bilaterally, and also no B lines visualized. And in summary, this is a 24-year-old female that presented with a recent CVA and a newly detected diastolic murmur, and it demonstrated features of rheumatic mitral stenosis with a characteristic anterior leaflet doming, thickening, and subvalvular involvement. I thought there was mild reduction in the LV systolic function with preserved RV function and no overt signs of pulmonary hypertension. There were no pericardial effusion. The findings I thought support a rheumatic etiology of mitral stenosis with moderate hemodynamic significance, and that mitral valvular area is 1.15 centimeters squared. And this, most likely, putting it into context, contributed to the patient's thromboembolic event, and that's why she was put for a transesophageal echo, and to rule out the left atrial thrombus and also PFO, and to guide management prior to the cardiac catheterization. And in hindsight, what happened with this lady, she didn't have left atrial thrombus. She also didn't have a PFO, and she ended up having a mitral valve balloon dilatation, and she did really well. Okay, thank you very much. Hannah, I guess it's time for the roasting now.
No roasting. Thank you so much, Pete. That was a really interesting case, and I think the first thing to say is I don't know this. I was just quickly looking at my phone. I mean, the prevalence of mitral stenosis as a result of rheumatic etiology in the UK is below 1%. I'm assuming it's a lot higher in Africa, but I don't know what the specific prevalence is in South Africa. Is it more common? Would you say?
Yeah, I can't give you a percentage value, but what I can say is that probably once a week, when we do mitral valve replacements, or even bivalvular aortic and mitral valve replacements, it's a rheumatic disease. That's one of the most common things that we see. And Bloemfontein, our region, gets a lot of patients from Lesotho, one of our neighboring countries, and they have a very high prevalence of rheumatic disease.
Okay, that's interesting. If anyone does come across a prevalence, stick it in the chat. Okay, I'm going to go back through and just give a little bit of it's not necessarily just for you, Pete, but for everybody that's in the room, just a little bit of tips on what they might need to look at to enhance some of their image quality for the exam, for example. So first of all, your interpretation was pretty much bang on, and I think that's a really good case to bring here. It's really nice that you described the appearance of the valve so descriptively, and I think sometimes we get stuck in this rut in the UK whereby templates of reports tend to be so structured that we lose that kind of narrative. And actually, even if you're less experienced in echo, actually just describing the valve is probably going to give you some more quality information. So this kind of tenting appearance that you talked about, the doming, that is a real sort of characteristic sign of mitral stenosis. And like Pete said, this hockey stick appearance is pretty much associated with this one etiology. There isn't really any other etiology of mitral valve disease that looks like that. So those little sort of pattern recognition tips are really helpful. You already spoke about the fact that, the M-mode calculation was done slightly incorrectly. I personally don't like M-mode, and I'll tell you for why, because I never just say I don't like it in my experience, and I've got to remember what I've put here in terms of, but if I just bring your attention to the fact that we're using obviously a 2D technology, or in this case it's a one-dimensional technology to assess the 3D organ, which is obviously the left ventricle in this case. So what I think then happens is that you risk potentially either under or overestimating the true dimensions of the left ventricle, and obviously that then has a knock-on effect on what your sort of volumetric measurements end up coming out as. And for less experienced individuals that would do a measurement and then take that as absolute gospel, that could then relate to somebody being labelled with an ejection fraction which doesn't really resemble their actual function. So I think what I would ask everybody in here is that unless your left ventricle is pretty much perpendicular to your M-mode cursor, I wouldn't hold too much merit in the measurements and the functional assessment that comes out of the M-mode. And I think that's something I picked up on quite early in my sort of journey, and as a result I've only ever really calculated things in 2D. And I think that's just something that I think most people kind of get to the point of realizing. But I do think that in TOE, where you do have the short axis where you can put an M mode straight through the ventricle, an M mode where you get ejection fraction, fractional shortening is actually really helpful, because often the LV is completely perpendicular to the cursor. That would be my only comment about that.
So, if I may ask, what do you use in your practice for function estimates? Do you do biplane measurements?
I do. So the gold standard for looking at ejection fraction is using biplane, which is obviously the volumetric model. The difficulty is, because we have different levels of accreditation in the UK, biplane assessment, and I'm not quite sure really why, because it's a relatively easy measurement to do, but it very much fits into the advanced bracket, whereas this kind of level of ultrasound is kind of bridging between basic and advanced, and as such you're limited to 2D measurements like what you've just done, or just a 2D assessment of the diameter in diastole and then systole, and then it obviously derives it from there. I think as we become more established with FUSIC HD, it will be likely that we'll integrate Simpson's biplane back in. I think the other thing to consider is that when we're doing things like Simpson's biplane, we are relying upon very good endocardial border definition, and that's not something we come across very often in the critical care setting. My sort of general idea will be, as technology starts to become better and better, it already is here now, the AI assisted ejection fraction tools that are already inbuilt in, for example, GE machines, I think they will start to become more commonplace in a kind of point of care ultrasound setting. And they're pretty good actually, based on what I've seen thus far.
No, I agree. Just to add on that is, I think in the perioperative or the critical air type of arena, to get a exact estimate of a ejection fraction is, a lot of the times it's not necessary. You can clearly see if it's not working, it's not contracting, or if it looks hyperdynamic, and the difficulty sometimes comes with that gray group in between. But I mean, obviously, just before putting someone to sleep, you want to know, does it look normal? Yes or no? That's where the binary question comes in and helps. So it's not a thing that I do often. I do biplane measurements, and again, the views that you get and the experience, and you need ECG as well with that. We don't have on every machine as well to do these type of measurements. But thank you. I'll take that into consideration.
I'm glad to hear about your sort of general avoidance over using sort of volumetric measurements, because the reality is I think your eyeball is probably far more accurate at giving, and actually even if your ventricle is significantly impaired, your patient may be hemodynamically stable, so it's not necessary that you're going to intervene at that stage. And I think certainly in the acute specialties, I think people are more likely to take note of the hemodynamic impact of that function, as opposed to reacting to an ejection fraction falling into a sort of lower category. So certainly in a FUSIC capacity, we do advocate not necessarily using it. But I do think it has place in medical settings, you know, cardiology, when they're looking for those minor improvements in ejection fraction. Not necessarily for us. Yeah, I love this picture. If I always do that, I'll flick back and then let me just go forward. Your description of how the interaction between mitral pathology can interact with your aortic valve function, even if your aortic valve is completely normal. And I think you're right. I think because of the distortion of the apparatus of the mitral valve, you probably have got a little bit of AR as a result of the remodeling. Not least because you've likely got some degree of pulmonary hypertension, even though on this particular scan it didn't necessarily measure particularly high. I've just put a little bit of a tip here for everyone, and I wouldn't necessarily agree that this is the size of the box that's required. This is the one that's pulled directly from the BSc guidelines. But when we're looking at colour Doppler, what you want to do is, for the aortic valve in the long axis, is try and extend the box a little bit further back into the left ventricle. It's not necessarily true that your length of your jet correlates with severity, because it could be that you have a very small jet that just extends back into the ventricle. It's normally the width of the jet, but I like to capture all of the flow dynamics where possible. So here I would probably just extend your box just back a little bit, just to capture any additional information. The information that I'm referring to, and it's particularly important for people doing HD, is when you've got a situation where there's mitral pathology or aortic pathology, with what I regard to be a little bit of a hypertrophied ventricle, if I'm honest. I think we did measure it on your initial view, and it came up at 1.5 for your wall thickness. So that's sort of fitting into that kind of mild category. You want to look for any signs of LVOT obstruction, or even just a sort of mild increase of velocity. And I think actually just giving yourself a little bit more information by extending the colour box can just pick up on that acceleration of flow. Obviously, for those of you who are just coming into it, anytime you put colour on top of a 2D image, you reduce the frame rate. So don't make your colour box too big. Try and limit it to the area of interest. Just to pick up on this, and I think this is the difference between the guidelines. So actually, internationally, the guidelines are slightly different on LVOT measurement. The UK guidelines did used to suggest exactly what you described. We measure the LVOT diameter about 0.5 centimetre back from the annulus of the aortic valve. But it wasn't that long ago, I don't think, but they changed the guidelines. So now the guidelines are that you measure the LVOT diameter at where you would normally measure that annulus, so at the hinge points of the aortic cusps. Yeah, I don't think it makes too much difference. And I think reading through the rationale, it was because obviously it's subjective in terms of where people think 0.5 centimetre back from the valve is, whereas now we're measuring it exactly at a point where there is structure.
Yes.
So I think it's to try and reduce any variability. I personally think unless you've got a heart that looks particularly sort of empty, where the LVOT might have reduced in size, I think it's completely reasonable for you to use a standard measurement of 2 to help sort of derive your sort of stroke volume assessment. As long as you use that same measurement all the time, then that will be more than sufficient. And I think certainly for HD, it actually isn't a requirement for you to do this, because obviously you then have to square that number in order to get your cardiac output. Well, when you go through all of the iterations of the equation. So it's not necessary for you to do that, and an LVOT VTI would be more than sufficient when you're looking at sort of stroke distance. That was just a comment just for those of you who are doing it in the UK, because that will be examined on your HD day. Your annular assessment, your aortic assessment was spot on. The only thing I'd say, and again, it's just probably a difference in guidelines. So the UK guidelines are that we measure the inner edge to the inner edge rather than the leading edge. And it's
that's
strange.
the Europeans that do that.
Yeah. Well, I kind of agree with what they're doing, because we measure the distal part of the aorta from leading edge to leading edge. But the UK guidelines are that you measure the inner edge to the inner edge. But other than that, the exact sort of reference points that you measured were exactly as they should be. This was just a reminder to me of how we might be moving away from using and LA linear measurement and moving toward using a volumetric assessment of left atrium. And I guess the reason why I think that's more important now more than ever is because if you look at all the diastolic guidelines that are out there, none of them refer to a diameter at all. It's all very much based around volume. And one of my colleagues, Shagan Olisanya, who people will probably know very well from the world of Twitter, he did a study at Barts where he works, and actually they were trying to figure out what the correlation between tissue Doppler derived E to E prime values were, and LV filling pressures, and what they found is that the highest correlation was between left atrial volume and pulmonary wedge pressure. So I think we got to move with the times, and actually I would suggest, if you're not already doing it, start to explore how to use volumetric assessment. And I think this really nicely exemplifies why the linear assessment might not be sufficient, because clearly across the whole of this very dilated left atrium, it's the diameter is very different across levels, isn't it? I mean, the old kind of reference point is at the level of the sinuses, but I would still think even that measurement there, Pete, would probably give you a sort of relatively smaller value than the true sort of reflection of LA dilatation. So it's just something to think about.
Makes sense.
Yeah. Inflow outflow views, I love these views. I think that they're probably the best view, like you correctly said, to do your tricuspid regurgitation Doppler, because you're often very much well aligned to get your Doppler through it. And it's just to say, you know, this is often how well aligned you can get your Doppler. This is just an example from the BSE guidelines. So if you guys are sort of coming into using Doppler, what I'd suggest is just do it in every single view that you can, particularly when you're doing tricuspid regurgitation, because you're looking for a maximum velocity. So you want to try and average that across and make sure that you get the highest velocity that you can. And Pete obviously measured that correctly at the peak of the waveform. I love the nice clarity of your outflow view. This is a really, really good view to look for any signs of dilatation, just visually. This is obviously a potential risk criteria for having pulmonary hypertension. There's not many things that necessarily go wrong with your pulmonary valve in the adult population. The most common would be pulmonary regurgitation as a result of pulmonary hypertension. So if I was to not necessarily feel that my gradient gave me a high sort of risk factor, if I did have pulmonary regurgitation and tricuspid regurgitation, I would be more suspicious that I wasn't quite getting the maximum gradient that I could, because it's often when you get PR in addition to TR that you actually have got probably a decent amount of pulmonary hypertension that's been undetected. I think, what did I put here? Yeah, you did a really good job of explaining this when we went through the scans, so thank you. We don't necessarily need to do this as part of FUSIC HD, but I do think it's a helpful measurement. If you are worried about shunt in any of your patients, I had a really, really good case where we had a pneumonectomy patient who just came out with looking completely okay, but was on literally just oxygenating at 70%, you know, like that was it. We couldn't get it up at all. And it turned out that this patient had a massive PFO, and we'd reversed the shunt by doing a pneumonectomy. So actually doing a shunt calculation using your RVOT and your LVOT VTIs, I think it's a really nice tip to do when you're worried about potential shunting in the heart. And the reason why I think it's not necessarily a difficult thing to do is because we're expecting you to do that to the LVOT, and it's exactly the same measurement. I wanted to bring your attention to this little notch that I can see here. I would suggest that might be characteristic of a bit of pre-systolic notching, which again fits with there being potentially a little bit of pulmonary hypertension that we haven't quite been able to measure. I think what you've done here was great. Again, very easy measurement to do. And the guidelines are, if your pulmonary acceleration time is under 105 milliseconds, then that would be a consideration of there being a raised pulmonary arterial pressure. And as you can see here, it doesn't measure particularly low. So I agree with what you're saying, that characteristically across the scan, we haven't been able to detect high PA pressures. The only thing I would say to these views is that possibly my eye was drawn to possibly a bit of septal flattening. I don't know if anyone in the room sort of feels differently, Pete, yourself, but I suppose it's because I already by now I'm skeptical that there is actually signs of pulmonary hypertension, and now I'm looking for it specifically. So, you know, maybe that's a bit of confirmation bias, but I would say possibly there is a little bit of septal flattening, which would not be out of context to somebody that's got significant mitral pathology.
If I can just interject there, is that I think that's one of the main reasons that they opted for doing a right heart cath for this lady, to put it directly. So I always try to remember that what we do with echo, it's not direct measurements. The gold standard for diagnosing pulmonary hypertension remains a right heart cath. So that's I think why they went for the right heart measurement, and she actually had mildly raised pressures on right heart cath, but responded well to oxygen. So a good candidate for the valvotomy. That's why they did it.
Yeah, and that's really valid. You know, ultimately what we're doing with echo is surrogates. But I think certainly more so now than ever post-pandemic, when we're considering whether or not somebody is likely to respond to ventilation long term, these are things that I think would be really helpful kind of risk sort of stratification tools. And, you know, certainly here, I would, you know, it makes sense now that they found something when they did a right heart cath. I love this view. We've got a really clear sort of view of how sort of crusty and restricted that valve looks. You know, when you've got that kind of sort of distribution of calcification, if you were to look at just this one view, we wouldn't be able to differentiate between it being a sort of general degeneration versus rheumatic. It's only because we've seen the other views of the mitral valve that we've been able to differentiate the two. But that sort of characteristic thick, echogenic, bright calcification, it fits quite nicely into what we've seen thus far. And the colour Doppler here, I think what it does more than anything else is it gives you an idea about the position of the jet, and that I think can help with determining etiology. You know, it's not as simple as if it's eccentric, that means it's structurally the valve, and if it's central, that means it's functional as a result of LV dilatation. It's not as simple as that, but I think at the level of sort of FUSIC and heart and FUSIC HD, it's a good starting point. So I think the fact that we've got a central jet here just means that we've got a relatively equal distribution of calcification across the valve scallops and leaflets. Nice little inflow-outflow view, outflow with our pulmonary findings that we've seen already. This is a really lovely view of your aortic valve, and that's what we're kind of expecting you to be able to demonstrate, so you can really hone in on that morphology. And again, the same thing with the on-FAS imaging that we do here. We can't really talk about severity. It's more the origin of the jet. And as we can see, it's very clear that that is central. I love the fact that you've got a nice apical window, because often this gets missed off the data set, and it's really important, you know, particularly in you know, patients who are septic and then a higher risk of like a stress cardiomyopathy. We always need to make sure we look at what's going on with the apex, but also for patients that have got really poor ventricular function, you know, we always have to be suspicious that there might be something lurking there, particularly if it's a late presentation. Now I think I've got something to yeah, this was just, I think you appreciated that your apical views were a bit tricky, and it's just for the guys in the room here, just train your eye to recognizing what a foreshortened ventricle looks like. This is 9 times out of 10 what you're going to struggle with in ITU, particularly because patients aren't well positioned. We're not able to get them over on the left hand side, we're not able to get their arm up. So we're kind of up against it, and what we can often do is foreshorten the ventricle, and this is a really good kind of easy way to describe what I'm talking about. You know, instead of that cursor going straight through the apex, it's kind of going through the back wall of the ventricle, and as a result we end up with this kind of globular shape. What that does, what the impact of that is that we probably could potentially overestimate the function, because it will naturally look more hyperdynamic because we're not truly going through the apex. The apex is meant to be still. Therefore, we get a general hyperdynamic sort of appearance to the apex, and we obviously will potentially make the ventricle look smaller because we lose that kind of cavity volume. So it's not to say for everyone in the room that you can't use an image like this toward logbook, or you can't use it toward clinical management, but always contextualize it. You can report that you've had difficulty with your apical findings, and therefore you just need to put it into context. And I'm conscious of time, so I'm going to whip through the last few slides. This was just another sort of reminder about box position. I think this is actually too big here, which is a surprise it ended up in the BSE guidelines, because that's all they ever go on about at the exam. But put most of the box over in the atria, just so you can pick up on any high-powered jets, particularly the ones that end up wrapping around the wall of the atria, which can sometimes be quite difficult to detect. I've took this from a website it was from a YouTube video actually. I really like it. It's just a kind of reminder of what kind of jet characteristics we're looking at. So we're looking at the body of the jet, the neck of the jet, and how much of this convergent zone that we can see over on the ventricular side. And you referred to it as a PISA, which is exactly what it is. Really, for me, at the level that we're at, the most accurate and helpful is the width of the jet as it goes through the orifice, because that directly correlates with severity. And I mean, obviously this is not the jet that we're looking at on the scan. That's a really helpful thing to look at. You correctly did a pressure half-time assessment, but for those of you doing FUSIC HD, this is not part of the data set, but I'm glad that we've done it, because it just shows us how we're sort of taking echo to the next level. Ultimately, with a mitral valve, because it's biphasic, we're looking at the mean pressure gradient across that valve. Okay, so it'll give us all of these things, but we need to make sure that we report on the mean findings, which if you look in the guidelines, as Pete said, it's over 5 millimeters of mercury. I've just added a couple of slides here just so you guys know the expectations for FUSIC. What we do expect you to do is pulse wave Doppler to check your mitral inflow, so we can start to build a picture of the diastology. I should imagine with this lady, even though she was in sinus rhythm, I should imagine we would have seen a reduction in her E wave velocity, which you may have done. It just I don't think I got it on the clips. And then we would also follow that up with a tissue Doppler, like Pete done on the right side, and then obviously on the left side, we'd be looking for a E to E prime value, which would give us some indication about fitting pressures. There's not much to say about your MAPC, even though that says TAPC there. It's just this is a common thing that happens on the exam, where because of the measurement that we use, we sometimes can't correctly see the baseline with a horizontal kind of crosshair. So just remember, guys, it's the vertical height that we're looking at. That was just another sort of comment on the tricuspid jet. We'll move through. I really like this, that you've included it. It's not necessarily part of FUSIC HD, but I actually think it should be. Again, for the same reasons that we're doing LVOT VTI, RVOT VTI is exactly the same. Right heart is very under measured, I think, generally speaking, and actually an S prime value like this is actually more accurate at assessing longitudinal function than TAPC is. So if you do get the option to do that, then do measure that, guys, and remember anything over sort of 10 or 12 is regarded as normal systolic function.
Can I just ask, Hannah, is that though the one on that image, is that the isovolumetric relaxation time though that's labelled?
Yeah, it probably is. It's here. So the first, yeah, be careful of that. I'd rip this off So I think that obviously this is on Piet's image. So that's obviously your first positive deflection, but it's this one here, which normally is aligned with the T wave of the ECG. That would be your systolic.
I see. Around there.
It's really tricky actually, because those are almost fused. You could actually convince yourself those are but good spot actually, Samson. This can happen when patients not going particularly fast, but do think about that. This is why ECG is really important when you're doing tissue Doppler, because it's really tricky to figure out where you are. But yeah, the T wave is normally in line. Yeah, Pete
I think
did
that's
the
volumetric relaxation time. It's that's the volumetric contraction time, isn't it?
yeah.
Just
One of those.
Correcting
One
myself.
of those little one of those periods in between the good stuff. Yeah, Pete measured the tricuspid regurgitant jet, and it came up obviously as below the threshold. And you know, that could be for many reasons. On ITU, we changed the loading conditions so significantly that we could be masking what is actually quite a high velocity. So it's something to consider. Pete, you said yourself that this image caused you a bit of drama, and it's just a two-chamber is a complete difficult image to obtain, just because if you look at where your probe is, you're trying to get the longest portion of the probe through a rib space, which is the same distance. So don't don't get frustrated with these views, but because you'll get there in the end. But in ITU particularly, these views are going to be difficult. As it happens, I think you've ended up with probably one of the best views of the mitral valve here. As it happens, it's helped significantly in your assessment of the mitral valve. And yeah, this can be a tricky view as well, but I think it's come across really well. And again, we can see the complexity with that valve kind of trying to open but not quite being able to. So in summary, everything you said was bang on. The only things that I would change are based on the fact that we have slightly different guidelines in the UK. So when it comes to ejection fraction, it used to be that we would categorize them by mild, moderate, severe severity. But the guidelines now are pretty simple, and I quite like them for that reason. So I do agree. Visually, it would probably be about 50%, and therefore it fits into a borderline low EF. Now, I say this because I'm trying to sort of advocate that we try and use categories like this. But the reality is, for FUSIC bedside stuff, if you were to say something is normal, impaired, or significantly impaired, that would also be completely sufficient. I do appreciate that a lot of you are using FUSIC HD as a kind of stepping stone to get to more advanced. I've just added here that there was a bit of hypertrophy, and for those guys who want to learn a little bit more about mitral assessment to the level that Pete's done it, download the EchoCalc app from the BSc, because all of your grading assessment is here. And as you can see, anything under 5 is regarded as being sort of pretty much normal. Pressure half time, obviously, the more time it takes to equalize pressure, the more severe that severity of stenosis. All of your LVOT and aorta assessment went completely bang on, and as were your right heart findings. It's just to make a point to the guys that are doing HD, don't at this stage necessarily worry about putting in any of the additional stuff, but it's something we can potentially look at integrating into the data set going forward. So with all that in mind, I pretty much wouldn't change anything that you wrote. I think this is a really, really lovely case, because what I think it does more than anything else is exemplifies how much remodeling happens with mitral and aortic pathology, and how that can have a direct impact on pulmonary pressures, and how that might impact what we then do with patients in intensive care particularly. So I think, for you guys that are starting out in HD, just look at all the valve etiologies, check the prevalences that are associated with them, and look at just the hallmark characteristics. Don't necessarily worry about the numbers at this stage. It's all about pattern recognition. And I think even without, you know, all of these measurements that we've got that have been very helpful, we could have made that diagnosis, I think, just based on the hallmark characteristics.